Welcome to the Microdosing for Healing podcast. I'm your host, Casey Garrett, and together we'll be discovering and learning from inspiring voices of healers, medicine keepers, and visionaries. Every episode, we'll explore the world of health, vibrant wellness, and natural medicine for a new era of human society. Welcome to today's episode. Hello, everybody. Welcome to the podcast. I am so excited to introduce and share someone with you that I speak about often by name. She is an innovator in the field, and I mention her to many of our communities gatherings and when I go talk on podcasts. So I'm really excited to put a face to a name today. Dr. Kristin Speer is with us. And today I'm really excited. I feel like this is the perfect time and year to gather around this topic because there is so much separation, or has been, between kind of the science worlds and the spirit worlds, the quote unquote natural worlds. And those two worlds are colliding in a beautiful harmony this year. And I notice from a guideship perspective, we're moving rapidly away from the either or mentality to a both and mentality. And people are really coming to embrace both. Like, you don't have to work just with pharmaceutical medications exclusively, and you can't work with earth medicines. You don't have to just be working with earth medicines and rule out pharmacy. You can have both, and both are actually optimal for a lot of people. So I'm really excited to bring this conversation forth with you today. Welcome, Kristin. Thank you so much for being here.
Thank you, Casey. Appreciate that introduction. It's a pleasure. I'm happy to be here.
Thank you. Let me introduce Kristin by her background as introduction. So Dr. Kristin Speer is a licensed pharmacist, board certified pharmacotherapist, that's a new one on me, and co-founder of the Psychedelic Pharmacists Association. Kristin has been at the forefront of bringing pharmacists' expertise into psychedelic care, advised Colorado on its regulated access program, and has created a practical harm reduction tool for guides and participants alike. She brings a unique and practical perspective on drug interactions and how to manage interactions around psilocybin use. Thank you so much for being with us today. So just to start off, I'm always so curious for guests to share, especially our clinicians guests who come from clinical backgrounds and academic backgrounds. How did you find yourself in the psychedelic world?
Yeah, that's a great question. And, I'd say my trajectory was very much influenced by my experience in 1999 when the Columbine massacre happened. Being from Colorado and being from Littleton, Colorado, that area, I was in class in a sister school of Columbine. And I remember during that day in April when the massacre and the events were unfolding on TV, but literally almost right next door, basically, same general neighborhood as our school. And seeing that kind of trauma and the fallout from all of that is what ultimately shaped my interest in not only mental health and wellness, but in hospice, palliative, and end-of-life care. There was a lot that I witnessed in the aftermath where we shared our school with Columbine students for the rest of the year. I remember taking half of the day and the Columbine students taking the other half of the day in the classrooms. And some very good friends of mine with some physical and emotional trauma related to the events that unfolded. So understanding, that event and how that pointed me in the direction and where I came from, I think is important to understanding how I ultimately embarked in the natural medicine space. And so I could have become a mental health practitioner, pharmacist, but I ended up going the end-of-life route. And so I've consulted my entire career on pharmacotherapy and non-pharmacologic management of pain and other symptoms in the end of life. And it's through that work that I was introduced to the real therapeutic healing, spiritual healing potential of natural medicines, particularly psilocybin mushrooms, in the end of life population. Didn't work with it directly, of course, because end of life is paid for by the federal government. A lot of the care is, and of course, people can't, there's no money or dollars traded for that kind of work and those medicines. But there was a lot of education surrounding what's up and coming in this space for palliation of symptoms and for end of life distress. And that's where I really dug into the science and learned that, being a DARE kid and part of the DARE programs in the 80s and understanding, what kind of blinders were put over our eyes, and understanding evidence and research, and assessing that evidence and research, realizing that we might have been duped and we need to revisit what really happened with these natural wonders, right? And with the chemicals inside of them and how they impact us. So it just, everything came to a point, a pinnacle, with psychedelics being in the end of life with human care and spirituality, and then also drug interactions, which are very much a part of, the end of life situation for folks. And all of that combined is kind of how it brought me to where we are today with the tool and getting into the space.
Thank you so much. One of the things I find so exciting right now in the space, and I'm really seeing this in our facilitator training program. So as guides to be are developing as their guideship, is lots of them are looking for resources and looking for things and communities and platforms that don't exist yet. And sharing with them, well, maybe that's yours to create. Right. We're at this very experimental, and the novelty of the field kind of lends itself to a lot of creativity and a lot of innovation. And in my humble opinion, Kristin has created, I think, one of the most innovative tools in the space. And I encourage you to share and share widely. I know it's a tool that I use near daily in my practice. And so one of the things that comes up frequently at the outset of practice is people say, I'm really drawn to microdose, but I'm on all of these medications. And so before Kristin's tool, people had to go seek out a doctor or a prescriber. And depending where they lived in the United States, for obvious reasons, there was some reluctance to do that, knowing what is this person going to take. Kristin has developed a tool so that people can actually cross-check in mere seconds their medications against psilocybin and check for contraindications, both for macrodosing and for microdosing. So I'd love to give you the floor, Kristin, to talk about developing this tool. And we call it the Magic Mushroom Interaction Tool. It's at psychedelicinteraction.com. So Kristin, if you could share with us kind of what inspired your creating this tool, just the story of how it came to be and any of the challenges, highlights along the way.
Yeah, you bet. The original purpose and the idea, the spark behind it was to share. And yes, I'm a very creative person at heart, but when we create, it's because we want to share, right? We create things to share with each other. And, but the real purpose was to get the information that I was keeping track of and developing and making it available to people. That's all it was. The tool was not designed to be a business, and for better or for worse, we're working around what that looks like right now. But most of the content and the information and the motivation behind this tool has been from my work in Colorado's Natural Medicine Health Act. And, drug interactions in general are just the pharmacist's wheelhouse. But when I started to look at ways to provide input and consultation and help shape and get involved with the Natural Medicine Health Act in Colorado, I started to build a database of interactions and evidence behind those interactions, or transparently lack thereof in a lot of ways. But thought, well, this is a question that a lot of people are asking, and it can't be summed down, reduced easily to a handful of concepts. It really can't, not even sometimes within the same medication class. There's differences. But to answer the question more succinctly, it just came down to wanting to make available the information I've collected to people, because the questions were out there. People want more information. They want to make informed decision. And I saw it as a way to get it up there. So I used my own resources to pull it together and put it up there quickly. And there was no, outside funding. I think there is a reason and utility for outside funding. It has a lot of benefits. But in my case, I self-funded it, put it all up, and got some pharmacist colleagues to kind of work with me behind the scenes to put it out there. And so here it is. It's been a labor of love. And again, wasn't designed necessarily to be a business. But now that we're moving forward in this direction, we really need to think more like business people a little bit, so that we can sustain the tool, right? something that's worth value, provides value, and is worth maintaining, needs support. So that's kind of where we are today.
Love it. I love it. I know a lot of listeners who are in the healing arts and guideship are nodding. Yes. The same goes for their work as well. When you do things from your heart, it's so easy to lose sight of the fact that they need to be sustainable long term. Right. So yes, thank you for speaking to that. One of the things I love, and like I said, the tool, since Kristin created it, I near daily am lending it to somebody, sharing it with somebody, because I think it's so empowering. And one of the things I love about it is a lot of people who are on prescription drugs are, reliant upon, consciously or unconsciously, on the prescriber looking out for them, right? And understanding. And when they run the report, they're not only learning how magic mushrooms will interact with their supplements and their prescription drugs, they're also learning a lot about the prescription drug itself. And so that, in many cases with my clients, is they come back to me and they're like, wow, I never knew X, Y, and Z about this drug that I've been taking sometimes for years and decades at a time. So just the empowerment and access that it gives people, I think, is pretty extraordinary. Another question I wanted to pose to Kristin today is, a lot of times we see clients that start off on one drug that might have some side effects, and they're put on another drug and another drug and another drug. So sometimes it's very, very common to have a whole people come with a lot of different drugs at once. I'd love for you to share a little bit, especially because you've worked so much and probably saw a lot of this at end of life care. How do you work with someone? How is it different when someone comes with a lot of medications that already might have quite a number of interactions between them?
That's an excellent question. And it's a bit of a conundrum, because there's various forces kind of pushing people to consume more, that they need this or that. And then other forces saying, you don't need this, pull it away, it's all useless, right? When the reality is usually somewhere right in the middle. And coming from my perspective, first of all, polypharmacy which is technically defined as taking 5 or more medications, usually ones that are systemic, things that go through your body, not necessarily like eye drops or something like that. But polypharmacy may be a result of side effects, and it often is, right? We don't know. Sometimes we don't realize that. But it can also very much be due to multiple chronic diseases. And so when people are on multiple medications, my one kind of piece of advice for everybody, even whether or not you're considering psychedelics or psilocybin, is that we need to check in. And what I mean by that is in the Western medicine culture in particular, and I imagine many other parts of the world as well, we tend to set it and forget it. And the problem with that is sometimes medications may be really helpful and necessary, and they're doing great work. They're keeping us alive, as in the case of statins and other cholesterol medications, blood pressure lowering medications. They're reducing risks, and there's evidence behind that to show that, right? In other cases, maybe medications are not so helpful, or maybe they were, and now due to some changes that we've made, they're no longer necessary. Or even in the end of life population, one of my favorite populations to work with, the benefits are usually seen longer term. So there's not enough time left to really see the benefits of those medications. For whatever reason, there may be no longer any reason to take a medication, right? And so I think we really need to start checking in with ourselves. Sometimes we rely too much on the provider to say whether or not something needs to be continued or not. Or the provider might ask us, and we were like, oh, I hadn't thought about that. I haven't really been paying attention. I just assumed I needed it because you've been prescribing it. So I think when we check in and we have this conversation with ourselves and with our providers or prescribers and even pharmacists, the question is, what is this doing for me? Am I seeing those results? When will I see those results? Have I done something so that I actually don't, am I doing things? Am I improving to the point where the medication is no longer necessary? And what are the side effects? Are they causing more problems than good? Is there an alternative that doesn't cause this problem? And the goal is to right size the medication profile for the individual. For example, finasteride. Finasteride is a medication used for, benign prostatic hypertension, BPH. And there's some evidence that came out of JAMA Dermatology a few years ago that pointed to the increased risk of depression and particularly suicidality, even in men without any kind of psychiatric history or pre-existing depression. And they compared this medication to other medications these men were using, in particular for hair loss. So let me back up. Finasteride is not just for BPH, but can also be used to combat hair loss. So it was found that this increase in depression and suicidality were seen in younger men, specifically using the medication for hair loss, not BPH. And it was seen in those who were taking this particular medication and not others for hair loss. Does this happen to everybody? No. Some men, for example, are doing just fine. They don't have depression. They're not having pictures of like suicidality picture. And they do just fine. But the point is, we need to constantly check in and reassess whether or not these medications are doing good or not doing good, and whether we could get along with an alternative, which may be another medication or a non-pharmacologic alternative. So long-winded answer to the question, what is the advice or guidance when you want to work with a medicine? You're on a lot of medications And I'd say the general concept applies. We may be adding psilocybin or another medication, right? Polypharmacy. And the idea is to be conscious about whether you need everything, and check in and have that conversation with your provider and with yourself and others about the benefits versus the risks, and whether you can start to peel things off, if it makes sense.
Absolutely. Beautiful advice. Yep. And I think what prompted, I know some of my clients have run reports on some other medications where, too, there's a potential for suicidality and increased depression that they had no idea existed. And it's not so much a contraindication, it's just psilocybin's effect of being a non-specific amplifier. It has a tendency to make more what is more. And so it's not necessarily a contraindication, quote unquote, but there is a potential to enhance or amplify other side effects that might happen with the drug. So it's very, very valuable to have these prompts and inquiries to open up a conversation about these topics. Like I said, for so many people, the vast majority of people didn't even know that those possibilities existed before they ran those reports. So yeah, beautiful. Thank you. Beautiful advice. I am so curious to geek out a little bit. I know a lot of the listeners who are listening today are guides, are going to be supporting other people, and they're going to be so curious about specific medications and specific learning. So with all of the data you have collected and I'm sure you see all the reports that people run and the metrics, I'm just so curious in the creation of the tool, what are some of the common medications that people are searching on? And has there been anything that really surprised you along the way?
Well, I think I have to clarify one little piece there, and that is that I really don't check what people are taking, because I don't really have a need, and I want to respect people's privacy. And that comes from my healthcare background, but also just because it's something that I want to keep private and protected as much as possible. So the only data per se that I collect is that necessary to get people their report, right? An email address, the medications, and we don't even really know whether those medications might be their own or somebody else's, or they're just kind of researching stuff. But I don't really have an idea of, like, based on real data reports from my site, because I'm collecting minimal information and I'm not really checking it because I don't really have the need. That said, it makes a lot of sense. And the medications that I have seen requested, and that's usually because I'm, corresponding with someone specifically about a question. They tend to be medications used for psychiatric conditions and neurologic conditions, which makes sense in the population that is looking to enhance and expand their wellness and health, with a substance or a plant medicine or a therapy used for mental health and neurology. So those are the two primary meds I would expect to see as most commonly checked. However, I think because of a lot of the somatic effects that we see from or within mental health populations and others tangentially is GI medications. I think we feel a lot of or experience a lot of symptoms in our gut, in our gastrointestinal tract, and also like other parts, right? Our joints, our backs, our knees. And so pain medications and GI medications, I think I've seen a bit more prominently, and would expect to be checked a bit more frequently as well. All that said, for what that's worth, I think what's interesting that has surprised me especially in the research that I'm doing, is when we're looking at psychedelic therapies, particularly with the larger doses, not necessarily microdosing, but it can also apply, is interactions with the context, the setting, the experience of the journey, which comes with the therapy. Whereas something like a blood pressure med you take in, your bathroom or your kitchen or wherever it is on a daily basis, and you don't think about it. You just go along your day, right? So there are medications that can cause problems during the context of an experience, a therapeutic experience, a journey, such as laying down. There's a medication that might create a really significant problem if you're laying down. And fortunately, there's an easy way to manage that interaction. There's an interaction with being outdoors in direct sunlight on a retreat, for example. Some drugs cause pretty severe photosensitivity, and that's something you'd want to know about. There's fasting versus non-fasting. Certain medications require you to take on an empty stomach versus other medications they require food, or you could take them with or without food. So I think that's something to consider. A lot of times we do go into a session on an empty stomach or with a light meal. And then there's medications that toy with the pharmacokinetics of ingesting a medicine or a mushroom, for example. So you have medications like GLP-1s that are causing slowed motility, and other meds can cause this too, usually to a lesser extent, that we need to pay attention to. So the good news is that interactions don't necessarily mean that you can't combine them, you can't take medicine. What they usually mean is we need to be cautious, we need more information, we need to learn how to manage them. How serious is it? Most of them are not super serious, but there are a few that'll catch you by surprise, and those are the ones we need to be watching out for and know how to manage those.
Love it. Thank you. What do you say to someone? Another thing that comes up a lot with clients is they use the tool, they run their report, and then sometimes in some cases, they're like, I would really benefit by talking to a person and doing a consult. So a couple of times cases that I see frequently is someone gets their interaction, they run the report, they have an understanding, but they're curious about tapering off of their pharmaceutical while they're microdosing is really super common. And in those cases, I do think oftentimes Kristin does consults also. And I think in those cases, you really benefit by talking to a person trained in pharma who can give you a very personalized, focused tapering plan. I think is one case where you would want to talk to a human being who is trained in addition to the tool. Another is, like Kristin said, when you have a situation of polypharmacy going on, where it's much more complex, and you would benefit by having someone's expertise to zoom out and see the bigger picture of other lifestyle things going on. So, Kristin, do you have any other additional thoughts where if a listener is on medications where they might benefit by using the tool as well as like booking a consult with you?
Yeah, I think the primary reason, one of the primary reasons that someone might book a consult is if they want more than just a one-to-one interaction check. So right now, the tool and any even regular commercially available drug interaction tools only check drugs one-to-one, meaning you have this drug, you have this one, and there's a potential interaction and maybe some evidence behind that. What they don't do, and what this tool doesn't do, because it's really very difficult to do unless you're human, a human professional, is compare all the interactions together, the whole mix. that's where the knowledge of a pharmacist or a clinical pharmacologist might come in, is to understand, how the mix works together and which interaction is probably carrying a heavier weight within that mix versus ones that are probably lighter weight, right? Not as serious or maybe not as likely to occur. So that's one reason, is when you want to check out the entire mix of medications together. And another reason is considering your own personal unique circumstances. For example, a very popular interaction out there that I think for those within the field has become a little bit less of a severe or flag is serotonin syndrome. And serotonin syndrome is very serious. It can be fatal. And it occurs when you have multiple medications that tend to increase the intrasynaptic between neuron levels of serotonin. Certain meds have more of an inclination to do this versus others. And this reaction is very rare. However, there are certain medications and certain circumstances that can increase that risk, right? So it's helpful to know whether or not something might, a personal risk factor or certain other medications that are not known as well, that might actually increase serotonin levels, to have somebody take a look at your list. Another example is blunting effects. I think this is probably an even better example than the serotonin syndrome one. That's where, for some people, risking potential blunted psilocybin effects in a journey, for example, it's not a big deal. And this is a possibility with long-term chronic use of serotonergic agents, SSRIs, SNRIs, SPARIs, for example. To some people, this is more of a recreational situation. Okay, they might be disappointed, but it's not a big deal if they experience like nothing, right? Versus someone else who is really hanging their hat on a therapeutic outcome, right? They're struggling, and there might be some desperation as well for this outcome, and they're spending a lot of money. And so a blunted effect, if any occurs, might be more devastating to somebody like that. And so a personalized consultation will assess variables like that, and things that are personally meaningful to the individual.
Thank you. Super, super helpful. Similar topic, I'd love for you to touch on your reflections on tapering. That guides always have a lot of questions about that. It's so nuanced, it's so individual, but there are some things we can share in terms of our approach to tapering various things. Far and away, the number one that I see is tapering off antidepressants. Is probably the most, with sleeping medications, probably a close number two that I've seen. So when someone's coming to you for specifically tapering, they're starting a microdosing practice and they're very interested in helping that support them coming off medications. How do you approach that in a consult?
Yeah, I've been consulting in tapering, which is part of a bigger concept called deprescribing. Getting off of medications, whether it's stopping abruptly, tapering, reducing, for a long time. And so I've been applying these concepts in this field particularly. And I would say the first piece of advice is very relevant to the very first, like one of the very first things you said when asking this question, which is it's very nuanced. I think that a lot of people are looking for help on their own, and I don't blame them. There's not enough help out there right now. But they're seeking input and guidance from published materials, Some of them are better than others. But ultimately, tapering is like tailoring. Tapering is like tailoring, as in tailoring clothes. So it's very personalized, and tapering really is not a cookie cutter thing. It really can't be. And I think that's where a lot of people are running into problems. Sometimes I'll encounter people who are in the middle of a taper and they're having a really hard time. And usually the situation is they're following something and they're going too fast. Maybe they asked AI or ChatGPT, which again, I don't blame people, right? They're trying to help themselves, and this is what they have available to them, right? There's not thousands and thousands of people who know how to successfully taper individuals. But usually what's going on is they're tapering too quickly, either in dose step downs or the duration that they're on a particular step. And, in the United States, the Western culture, it's always, I wanted this yesterday, right? And this idea of immediacy is not helping us. So really, tapering is a very personalized process, and it is a process. It's a system. It's not a one and done. Things usually need to be adjusted, even following conservative protocols. And they're personalized based on a lot of individualized risk factors. Maybe your kidney function is not what it should be, and medications stay in your body longer. Same thing with liver function. It depends on how long you've been on the medication for antidepressants or sleep medications. It depends on the dose. Are you on a higher dose or a lower dose? How well is your condition controlled? Should we even think about tapering off at this moment? Is there a way we can approach it more conservatively? People aren't thinking about compounding medications, and compounding is important when we get down to those really low doses. It's part of what we call hyperbolic tapering, which is probably one of the best approaches for successful tapering. However, it's very long. Sometimes if you're on a high dose of something that needs to be tapered and you've been taking it for a very long time, years usually, getting off of it successfully, sometimes it takes a year. And people aren't willing to wait that long, but that's often the most successful way. So that's the other point I think I want to make to the audience, is that if we're doing it right and we want to be successful, it takes a longer time than you think. And you should be prepared to take as long as necessary to successfully get off. And I do think microdosing can help. I think also, because I've done this, microdosing isn't necessary in all cases if it's done, if tapering is done right. But I don't think that it's necessarily harmful. I think that microdosing plays an important role for people who are getting benefit out of it, who feel like they could use a little bit of, a crutch, if you will, because tapering is not easy. It's really hard. The symptoms can be real. And the goal with tapering is to avoid those, right? If done right, we're avoiding withdrawal, we're avoiding these difficult symptoms. But again, I don't think there's a huge risk to supplementing with microdosing to help people across the tapering journey.
Thank you for that. I've seen many, many people taper, and I concur completely with take longer than you think in most cases that Kristin shared. The two things that I have seen with microdosing be very supportive is it helps soften the otherwise deep troughs that you can go through. There's a delayed lag time when you're tapering off of particularly SSRIs, where the taper you do today, you might not feel it for 2 to 3 weeks. and it can feel like falling off a cliff for people. And I've noticed that when people microdose through, especially through those valleys, they're not as deep as they would be. They're supported through that a bit. The other thing, and this one is really beautiful to witness, is a lot of times people who've been on SSRIs, particularly for 10, 20, 30 years sometimes, even after they taper, they've been so blunted for so long that they're blunted from feeling depressed, but they're also blunted from feeling joy and gratitude and wonder and awe and crying cathartic tears. And microdosing, particularly with mushrooms, helps access that wild, instinctual, like feeling part of themselves and brings that forth. And so I've seen people try to taper who have tapered in the past without microdosing. They're like, I still can't cry. I feel like I need to cry, but I can't cry. It's like I have this mechanism that like keeps me from it. And oftentimes when they start microdosing, that they're able to have those tears finally come forth. And it's a success to them after so many years of not being able to really feel their full emotional spectrum.
And very well said. And I have seen a story, a mutual story, I think, that you might be drawing from as well. And even mechanistically, when we talk about SSRIs and microdosing, we know that one of the mechanisms of psilocybin is partial agonism of primarily serotonin 2A receptors, but it does hit other serotonin receptor subtypes. And it makes sense that because it's not a full agonist, it kind of partially agonizes, that it sort of acts like a buffer when we're trying to taper off serotonergic modulators. The other thing I want to mention, kind of in response to that too, is I think there's a lot of potentially lay scientists, and by lay I mean they understand Western methodology and scientific methods and how research is done, but they're not as maybe involved in the psychedelics field, clinicians as well. Is I know in the back of some people's minds is what I'm trying to say, that the research doesn't quite support this picture. And I would say yet. So I think there is a lot of value in anecdotal stories. And there could be a lot of anecdotal stories. And I think that personal experiences and what we see is extremely important, are extremely important data points to methodological research, right? So, if you think back to the days where physicians used to think smoking was healthy, it takes time for research to catch up to what we're seeing in the real world. So to those, I think, who are skeptical of what's possible with microdosing, I think we will see that, probably a lot of it is true, at least partly, if not mostly. And I think Western medicine has this tendency to discredit or poo-poo things that are not evidence-based. And I would challenge people to say, or to think, that we need to wait for the research to catch up. Yeah, maybe we don't know that for sure. It hasn't been tested. But I think as long as risks remain relatively low, and people are experiencing benefit clearly, then we need to be open to that idea, even if the research is inconclusive right now, or not supporting it because we just don't have it, right? So I agree. And I think that's really important to say for anybody who's listening, that is very, Western medicine follows evidence, is evidence-based. I do too. I was trained in it. I dig into research all the time, but there is a credibility to real world experience, and a significant pile of anecdotes, all saying very similar things.
Mm-hmm. Indeed. I appreciate that. And I appreciate your diplomacy always. So this is an excellent segue into my next question. And one of the things I so appreciate Kristin's support in this. So one of the things as a non-scientist in the space is what I've really learned when I'm attempting to read through the science and the research to be able to translate it and relay it to my clients and other guides is science speak is quite different than regular person speak. And so I very often find myself providing people, well, here's the research, here's the actual scientific published study piece, and then here is a translation of it, what it means for you and to you. And there was one specific instance where there was some discussion online about a very popular topic in the field, which is, does chronic microdosing, long-term microdosing, potentially cause heart valve damage? Kristin, correct me if I'm wrong on that. And the way that it's put forth sometimes by the clinical community, it makes it seem the words are used like link to. And in discussions around this and getting clarification, Kristin has shared with me, those mean different things. Like certain words mean different things in science language than regular person language, right? Which has been really, really valuable to me as the research comes in, understanding what is evidence and what is not evidence yet, not proven. So it's very, very complicated. And as a non-scientist, when you're trying to read the science, it is complicated. So Kristin, can you share some reflections on that for lay people who are like reading these studies and trying to understand it? What are some of those things to have in your mind when you're trying to parse these things out?
And this could be a whole like episode on its own. And in my opinion, a very boring episode. So I'll try to keep it high level and as accurate as I can be. I'm not a biostatistician. But I would even say that even scientists and clinicians often struggle to understand the evidence. And most research and evidence and the literature that we see, right, published articles, is on a spectrum of confidence, a spectrum of certainty and uncertainty about the results that we find from those studies. And sometimes studies will be combined to paint a broader picture, right? We shouldn't be relying on this study here, but unless the study was extremely well done on a large number of individuals that represent the population that would be receiving the intervention. But I think getting to the main question and the terminology that can be confusing for people is this idea of association versus causation. In other words, does this factor, this thing, this variable, this intervention, this drug, cause, or is it associated with this outcome? And causing this outcome is a degree of association. We're never 100% certain about anything, really, except for maybe gravity. But the word link is just to identify a potential association. It doesn't say that something caused something. So when you hear this may be linked to that, usually what it means is within a certain set of studies or a study or whatever the research says, And usually it's observational. It's looking back on something. It's not set up like a randomized controlled trial. It's saying that there is an association found based on how they designed the research that says that this variable seems to be linked to, associated with this outcome. Let me give you an example if I can. Sleeping and nighttime. They're very strongly correlated. They're very strongly associated. Humans and animals, most who are nocturnal are not nocturnal, diurnal, we sleep at night, right? So if you're some outsider entity trying to study sleep, you're going to find that most people are sleeping or fall asleep around nighttime. Does that mean nighttime causes sleep? No. Does that mean nighttime is associated with sleep? That's probably what we're going to find. Nighttime and sleeping are linked. But it doesn't necessarily mean that nighttime causes sleep. There's some evidence out there, that is stronger. There's evidence that is weaker, meaning strong evidence, there's more of a reason to believe that this causes that. Like, I think the audience will relate to ACEs, adverse childhood experiences. Studies have basically established a causal relationship between severe childhood trauma and poor health outcomes as an adult. Ideally, one of the gold standards when we establish a causal relationship with something between between a variable and an outcome, ideally we like to have the gold standard, which is a controlled prospective interventional study, right? Something that is controlled environment, you give it an intervention, and you're looking forward to see what happens to your populations on the other side. But a causal relationship doesn't necessarily require a controlled prospective interventional study. And sometimes it's not practical to do so, or it's not ethical to do one of those. And so there are other ways to determine whether there is a causation or a very strong association or correlation with something that might people be more confident about causing it or calling it a causation. And there's a lot of factors that go into that. Going back to the potential link between chronic microdosing of classic psychedelics and valvular heart disease, there's no, we don't have the gold standard study, but there are some elements that are they warrant a signal and they warrant a little bit of caution. For example, the link, one of the primary links seems to be that the agonism, the stimulation of serotonin 2B receptors. We see medications that have been withdrawn from the market, ones like pergolide, fenfluramine, benfluorex. These and those, that was in the European market. These agents have high serotonin 2B receptor affinity. They've been associated with valvular heart disease and pulled from the market for those reasons. Cabergoline is another one that's similar, with a similar mechanism. It hasn't been pulled, but it does require an echocardiogram and echo monitoring on higher doses of the medication. So all of these studies kind of paint a picture that we need to maybe pay attention to. And they're with chronic dosing. We don't have solid information in humans at all. We don't even really have solid information in animals at all about psychedelics, right? We do have better, stronger information about these medications that were pulled from the market. But I think, what do we do about this information? We realize we need to be careful and recognize the types of studies they come from. And that's really hard to do, even as somebody who's been trained to look at studies like this, or even conduct studies. But we need to recognize that it is a signal. There seems to be a potential link based on all these data points and studies. But I do also think that we don't want to be overly cautious. We don't have data yet that says definitively that microdosing chronically poses zero risk to heart valves or any other risks for that matter. We just don't have the data that says that. Have people been taking these medicines and microdosing for a long time? Yes, but we haven't really tested their heart valves either. I think where we can kind of land is in the middle, as usual, and realize that, yes, there's this signal, and we need to, and it's associated more with chronic use. So, maybe what we want to do is pay attention to that signal, be conservative, be cautious. But does that mean everybody needs to drop microdosing this instant, considering that they're getting quite a bit of personal benefit? It kind of relates back to the check-in piece too, right? Risk versus benefit, having that conversation with yourself, maybe your provider, if they're willing, or, if there's not too much stigma or concern there. But recognizing that, the best approach is probably somewhere in between. And if there's ways to check in, take a break, and potentially, we don't know, potentially reduce the risk of valvular heart disease by taking a break from time to time, then great. And it's also your personal decision to move forward, because maybe that's not enough evidence to convince you. And I think that's a fair approach too.
Thank you. Super, super valuable. And I think too, where we at now, I know for, even 5 years ago, this was still not very well known. It was very fringe, and you kind of had to seek it out a little bit more to participate. And so the person who sought it out, right, was also willing to do a little bit more exploration. Now that it's very mainstream, people across all of society are coming to practice. I think too, there's more of a risk for people using science to promote their particular viewpoint too. And so I think it's very, very important now to do as Kristin suggests, to slow down, really understand what it's saying. And I know I appreciate having Kristin and other clinicians and scientists in my world. If I don't truly understand what something is really saying, and I think there might be somewhat of a vested interest in where it's coming from, right? I have these colleagues to take it to really peel it back and explain to me what it's actually saying. So thank you for being one of those people. Yeah. Shifting over to, I'm so curious, with your experience with advising in Colorado. I think we have a global community. There's many, many people who they know vaguely that Colorado has been real leaders in the space, but definitely don't know kind of the details and nuances and the journey that got you here today. So I would love for you to share, from being inside Colorado and being part of that movement, if you could share some of the things and takeaways in that process that were very valuable, that others, could benefit from in their states and their countries. And also some of the things, if any, if there's things that you wish in hindsight could have been approached a little bit differently.
Sure. I would say, first of all, I wasn't involved in every aspect. That's very challenging to do. And I was not on the board. I think that's important to say. I did not sit on the board of advisors to Colorado. However, I did advise the board and some other entities who were very much involved in policy making and rulemaking and shaping. I want to be careful about what I found useful versus what I think your audience will find useful, because there's a very personal, professional motivation behind my involvement with the Natural Medicine Health Act, and that is pharmacists are seen as dispensers at CVS and Walgreens and Rite Aid, and I think we're missing a wealth of perspectives who are interested in patient access, and a wealth of perspectives related to fair, safe, ethical, and effective use of substances, or whatever you want to call them. And pharmacists are that wealth of knowledge and advocacy and expertise that I think we're forgetting to bring to the table. So putting that personal, professional piece aside now, I think that the journey and what Colorado did, being only the second in the nation to legalize and roll out this program, is they listened. I think there's always room for improvement. The biggest room is always the room for improvement. And while I think Colorado listened really well, including inviting perspectives from pharmacists, including myself and some others, Indigenous perspectives, I think that's where programs going forward can learn, is to invite and listen as much as you can. Invite people to the table, particularly Indigenous folks. I think, Colorado did what they could with what they had available, with what they knew. There's such an urgency for mental health care, especially, I'm partial, but especially in Colorado. I feel like since Columbine happened, there's just a lot that has occurred in Colorado, particularly, and across the US. I think Columbine sparked something that was not good. But there's such an urgent need for mental health care, not only in Colorado, but across the United States and the rest of the world. I understand why there was a push for this bill and for this program to roll out, and why there continues to be a push. But if we want to do this right, we need to bring tribal cultures, Indigenous roots to the table early, at the very beginning, the very start. Colorado created an Indigenous working group that I think was a good move. But I think we need to be bringing tribal representatives to the table at the very beginning, even with shaping the bill, or even if there's a step before that. I think that's really important to create something that is truly effective, fair, healing, equitable. There's a lot of reasons to bring more perspectives to the table, and particularly those that have been using these substances for thousands and thousands of years. And I don't even like to refer to them as substances, because I know what these spiritual entities mean. So I would say that's probably one of the biggest rooms for improvement. But Colorado's process, I think, did as good of a job as they could. Lots of input from a variety of individuals, so-called experts like myself, so-called non-experts who contributed significant amount of insight and input and valuable information, lay people, who've been using medicines for a long time. And I think what was also interesting about Colorado is because they wanted to create this sort of hybrid model between more of a personal adult use, which is how Oregon's model is characterized, and more of a medical use. Colorado's not fully medicalized, and it's not really just adult use only, it's kind of in between. And to help shape the program in that way, they partnered with healthcare professionals from the University of Colorado to provide more input and information into safety screening criteria and so on. I was part of that group, and I thought that was a good move, and just highlights how interested that I believe Colorado was in listening and garnering perspective from multiple types of people and professionals, non-professionals, to make it the best they could. And it's not the best, but it was good. I think it was a great starting point and precedent that a lot of other states will be looking to build off of and improve.
Thank you. Super, super helpful, inspiring, and I don't think scratch the culture at all. I think that was a really, really important reflection, actually, because I think when we do listen to these diverse and often lesser heard aspects of our history, those are the most valuable pieces in the way we hold and frame the medicines,
Sure.
the way we used to.
Culture came out and it might have fit, but I think I was looking for something more specific. But if it works, go with it.
I vote in. Yes.
Okay.
Beautiful. Thank you so much. Is there anything else in closing? Of course, we'll put all of the links and so forth in the show notes, especially for the tracking tool. But is there anything else in closing that you would love to share in this moment? I find when I talk to guides, they've really been speaking to the fact that things are really shifting right now this year. What they're seeing, the needs of people are really, really shifting significantly this year. So just in closing, if there's anything that you would like to share in terms of kind of zooming out what you're seeing in the field, what you're seeing in your clients right now, that'll be helpful and inspiration going forward.
People are looking for personalized guidance and personalized help. And if you're following and checking the tool, psychedelicinteraction.com, you'll see over time more and more things and resources added. So right now, for example, there is a consulting pharmacist page where I plan to feature more pharmacists who are working to provide support and help and pharmacologic management around psilocybin and potentially other journeys. We'll see where this goes. And that was one of the original visions of the tool, was to create an avenue, a starting point for people to kind of check. And then if they needed more support, pull in these pharmacists who are knowledgeable. They can provide help and support for people. There's such a huge demand. We need more professional guidance and advice where it's needed to, build confidence around not just microdosing, but, larger macro doses of psychedelics as well. I do this myself. Stay tuned. I have been working on consulting and doing this kind of quietly for a while, but I'm getting ready to roll out my services for screening and medication management around psilocybin journeys, and might be expanding that to other substances. We'll see. But I think that, as people are looking for more support and help, meeting that demand with the demand of an entire profession of pharmacists that are looking for something other than potentially dispensing at a counter. There's some that are still very happy doing that, and that's very valid and it's necessary. But there are a lot of people who are sort of done with that type of role and want to be more involved with more of a guiding, consulting, patient care role in this space. And that's a great match. So I like to see that, and that's what I'm working on. Also, I think it's important for people to understand that this tool wasn't built to, like, as I originally mentioned at the beginning, it wasn't built to drive money back to me. It wasn't a money grab. But we need to also understand that in order to sustain something valuable, it needs to be supported. So, and it needs to be shared if it's supported and used. And it gives back. So I think that's the other piece to this is I've always intended for the tool to give back in some way. It's giving back to the primary user, the end user. It's giving back to pharmacists. It's giving back to Indigenous folks. A minimum of 5% of any profits, if not more, if we become successful, not just sustainable, but successful, will go back to Indigenous communities in Colorado and potentially other states. I think I'll leave it at, if you're interested in supporting the tool in a meaningful way, check out a report, share feedback. I intentionally made a way for people to send feedback via the tool. If you're looking for a particular medication that's not listed, if you're wondering about the evidence behind it, any questions, maybe you ran into a glitch, that's the whole purpose of the feedback button. It goes directly to my inbox. And so far the feedback has been good, or, sending requests through. But yeah, I encourage the feedback. We more than welcome it. We seek it. I seek it all the time. I think the other thing is, if you do share this tool, share humility, share grace. If you share this tool, share humility, share grace. And the reason I say that is because that's how it was built. That's where it comes from. And also, like, I don't think my tool is perfect. I know it's not perfect. And I'll come out and say that it's not perfect, but it's helpful. And I think it's filling a gap that is important. And it's a reminder that as you're sharing the tool and talking about it, and as you come to the tool and use it, we're human beings creating this thing. We're not using AI to create the content. It's very organic. Like there's over 20,000 FDA approved medications, and probably more OTCs and, over the counters and supplements and herbals. We're a small group, and we're trying to maintain the tool and grow our group so we can make it bigger and better. But understand that, a few humans can only do so much work behind the tool. And so that's why we welcome your feedback there too, is, if you see something that's not on there, submit it. And if there's evidence and there's some information that we can provide, we'll work to get it on the tool. And then also, technology is sometimes our greatest friend or our biggest enemy. So if you run into any issues or glitches, or you receive something or don't receive something you weren't expecting, just reach out and we will make it right. So
thank you. I do. I so appreciate you, what you do, and especially how you do it. So thank you so much. And one of the things I love about the tool so much is as I opened with, like, so many of you listening are the leaders of the future. It's really up to you to create that which you seek. Right? If you see a gap, if you see a need, if your clients are asking you for something, if you see the public and society need something, we are going to be the ones to build it. And it's inspiring, it's courageous. And so I hope all of you listening and hearing Kristin speak so candidly, vulnerably, and honestly about what it's like to create something that's never been done before, that it inspires you to go forward and make that thing too. Because that courage is contagious, And I hope whatever it is that you have seeded inside of you right now that you wish to create in the world, it's evidence to just go do it. Go do it. Yeah.
Yeah, absolutely. Yeah. We all have something to create and to share and provide value for others. So I agree.
Thank you so much. How can folks find you? We will, of course, put it in the show notes, but for those of you who are driving, I see you and are listening. Can you share with those people listening in the audience where to find you online?
Yeah, you can reach me at info@psychedelicinteraction.com. That's the primary route. And then if you're ever on the site, scroll down to the bottom, click that feedback button, and it goes to the same inbox. So that's the best way to reach out.
Beautiful. Perfect. And Kristin is also on LinkedIn,
yes,
which is, I think, how I found her work initially. So yes, for all of the guides listening in the audience, you are welcome to reach out to connect with her professionally on LinkedIn too.
Yes, please do. I look forward to connecting.
Beautiful. Thank you again, Kristin. Thank you all so much for listening. Thanks for being here. And we will see you back in a couple weeks. All right. Have a great day.
Thanks, Casey. Thank you all.
Thank you for listening to the Microdosing for Healing podcast. Ready to take the next step? Please visit us online at microdosingforhealing.com. There you'll find lots of information about our global community, professional training programs, and upcoming immersions. See you there.